Thank you very much, Marco, and the organizers for inviting me to this lecture. In the recent years, there has been a huge tsunami of biomarkers in heart failure, and with the time I have, I'm not going to be able to go all over the biomarkers that have been reported to have some value in heart failure. So what I did is to propose you some of these biomarkers that have passed the stringent statistical pathway that provide us with some relevant information. What is that relevant information? On the one side, is this a biomarker that the clinician can measure? Number one. Number two, is this biomarker adding a new information into what we already have? And number three, will the biomarker help the clinician to manage the patients differently? So I've tried to put all the biomarkers in this talk that do answer these three questions. And to answer these three questions, the biomarkers need to go through important rigorous evaluation. And this evaluation means discrimination, calibration, and reclassification. Nowadays, area under the curve is not enough to say that the biomarker is valuable. You need to make sure that area under the curve is significant. You need to make sure that the model that you generate with the biomarker on top of it has a good likelihood, Hosmer-Lemmer-Schaup calibration, Akaike information criteria, Breyer score, and likelihood ratios, so that's calibration. And furthermore, we now need to provide evidence on reclassification, net reclassification index, and IDI. So we need to get the biomarkers to fulfill all these statistics. And once you start playing with the biomarkers, you realize that this is not easy. And I'm going to give you an example. You are not going to hear about galectin-3 today, because galectin-3, which is a good biomarker and it has some relation with the pathophysiology of fibrosis, when you put it in a multivariable model with all these statistics, it just doesn't stand. I'm not going to talk today about cystatin C or NGAL, because in the setting of heart failure, these biomarkers do not provide additional information to the clinician. So at the present time, the guidelines, the most recent guidelines from the AHA-ACC, they already give us some clues on which are the biomarkers we have to use in regards to those that have more evidence. On your left, you have prevention, diagnosis, and prognosis and risk stratification. On top, you have the AHA different stages, A, B, C, D, and also hospitalization. You can see that in green, you have natriuretic peptides for diagnosis and prognosis. You have in orange, which means 2A, natriuretic peptides for prevention. Green means 1A. And then you have in yellow also 2A for admitted patients, pre-discharge natriuretic peptides, and in more darker orange at the bottom of this figure, what they call other biomarkers of injury or fibrosis. This means cardiac troponins that we already heard about, and other biomarkers of fibrosis. And I'm going to focus on ST2, which is the biomarker that appears to be better suited to get into the clinic relatively soon. So when we study different biomarkers that may participate in heart failure, I like very much this 7H star from Jean Brownwell, because we need to address biomarkers that tackle the different pathophysiological pathways of heart failure. And these are myocardial stretch, myocyte injury, matrix remodeling, inflammation, renal dysfunction, neurohormonal activation, and oxidative stress. If we are able to provide biomarkers covering all these stars, we are probably in a pretty good shape to provide a very comprehensive evaluation from a biochemical point of view of this heart failure patient. So what do we have at the present time? As far as multimarkers in chronic heart failure, we have to bear in mind that natriuretic peptides, BMP or NT-proBNP, are always going to be there, because this is our standard biomarkers. So I looked for papers that had 2, 3, or more biomarkers, ambulatory patients with heart failure, and we have at the present time 4 good cohorts that are well characterized, and they fulfill all these stringent criteria I just told you before. And this is the Penn heart failure study by Bonnie Key, the PROTECT sub-study from Hannah Gagin and Jim Zanuzzi, the Singapore Heart Failure Outcomes and Phenotypes study from Mark Richards and Caroline Lam, and the Barcelona BioHF calculator from our group. So let's go to see these 4 cohorts and see what do they provide us. So the PHF is a multi-center cohort, 1,500 patients. This is mainly systolic heart failure, so it's HFrEF, class 2, mainly also 3. Treatment is correct up to guidelines, and they use as a baseline model a well-recognized model, which is the Seattle heart failure model. The primary endpoint was death, transplant, or VAT, and a median follow-up of 2.5 years. This is Bonnie Key, and this is the Brownwell star in this trial. So they used BNP for stretch, troponin I for injury, ST2 for matrix remodeling and inflammation, CRP also for inflammation, creatinine for renal dysfunction. BNP also provides surrogate information of neurohormonal activation, uric acid and myeloperoxidase for oxidative stress, and SFLT1 as a vascular remodeling biomarker. So this is a very, very comprehensive study. If you want to check medians and IQR, here you have them for all the biomarker profiles. They did have 317 outcomes, 187 deaths, 99 transplants, 31 VADs, and these are the main results. So they picked 7 markers which remained in the multi-marker scores, and these were BNP, SFLT1, CRP, ST2, conventional troponin I, which was measured as detectable versus not, uric acid and creatinine. And when you look to the risk estimate, you get a high multi-marker score with a hazard ratio of 15, which is very high, an intermediate 4.5, and a low, which is our reference. So when you have all these 7 biomarkers which are low, you have probably a very, very good outcome. When you look this into areas under the curve, look at the Seattle heart failure model, 0.76, which is quite good. The multi-marker alone is 0.83, which is very good. And when you combine both, the clinical approach with the Seattle and the multi-marker, it's 0.92, so you don't get too much of a gain as far as discrimination. But when you use risk reclassification at 1 year, comparing the Seattle heart failure score with the Seattle plus this multi-marker score, you get an improved reclassification by 18%. And an 18% reclassification of a patient from mid-risk to high risk or mid-risk to low risk is a very substantial reclassification. The only problem with this study is that it's very unlikely that anybody from this room is going to use a minimum of 7 biomarkers in the near future. So it's very nice to get this data, but very unlikely we're going to use that. So the PROTECT study is a post-hoc analysis from the PROTECT trial by Jim Januzzi. This is a small trial, 151 patients, age 62. It's mainly HFrEF. The primary endpoint is a combined MACE endpoint with most of the events from the cardiovascular origin. A follow-up that's also shorter than the other follow-ups that I will show you. Here is Hannah Gagin, the main author from this paper, and Jim Januzzi, the AP. And here we have NT-proBNP, high sensitivity troponin T. In this case, it's a high sensitivity value, ST2, GDF15, EGFR, and NT-proBNP. So it's covering most of the STAR except for oxidative stress. Let me tell you that there are no good oxidative stress biomarkers right now in heart failure that can stand all these multivariable models. I'm not going to go through this slide because it's a heavy one. For those of you who are interested, you have all the clinical data by the strata of ST2, GDF15, and troponins. But I'm interested to go through this one. In this case, the authors provide on your right side the AIC, which is the Akaike information criteria. And they compare this AIC with the traditional clinical and biochemical variables on the top. So you get on your top the conventional variables, which is a number of clinical variables plus NT-proBNP, which is 419. And let me tell you that AA key tells you that the lower the AA key, the better the model. And there is no p-value. So the lower the AA key, the AIC, the better the model. So as you go down through your variables and you start adding ST2, GDF15, HS troponin T, and so forth, your AA key goes down to to down here, when if you add the 3 biomarkers, you get the lowest AAC from this study. So another interesting approach of combining biomarkers all on top of a baseline clinical model. This is a recent study that I think it's very interesting from Singapore. Mark Richards on your left, Caroline Lam on your right. This is a multi-center cohort from Asia, 916 patients, quite young, 61. And it's very interesting because in this study, they do have a percentage of patients with HFrEF and also with HFpEF, with preserved ejection fraction, over 50%. Mostly class 2, good treatment according to guidelines. The baseline model is very similar to many others. And their primary endpoint was the composite of death and hospitalization with a median follow-up of 23 months. This is the star of Brownwall, NT-proBNP, HS troponin T, GDF15, EGFR, NT-proBNP. And also, let's not forget that sodium and hemoglobin are also biomarkers that give us information about some comorbidities that this patient with heart failure also has. We need to bear in mind that anemia and iron deficiency is very important in heart failure, and sodium is also a predictive value of cardiovascular outcomes. So the SHOP study, this is your biomarker profile. The composite endpoint was appeared in 379 patients, 81 deaths, and 298 hospitalizations. And interestingly here, what you can see that both in HFrEF and in HFpEF, GDF15 is a good prognosticator in these Kaplan-Meier curves using tertiles, as you can see. And when the authors on the bottom provide the hazard ratios for NT-proBNP, high sensitivity troponin, or GDF15, you can see that the higher ratio is for GDF15. Then we get the troponin, and finally the NT-proBNP. So I am telling you that when you start mixing biomarkers in this multi-marker approach in chronic heart failure, the newer biomarkers appear to be somewhat even stronger than NT-proBNP. In the SHOP study, the baseline combination of biomarkers provide us an AUC of 0.72 plus GDF15 0.74, and again, NRI pretty much similar to our initial study, the Penn study, 18.3%. So this seems to be pretty good NRIs. In our case, we did a single center cohort of almost 900 patients, mainly HFrEF, class 2, mainly 2, 3, properly treated. A baseline model, in this case, we included not only the clinical variables, but also treatment, because that has to do with the outcome of the patient. So we need to incorporate whether the patients are treated or not with the beta-blockers ACE inhibitors, which are indications 1A in heart failure. Primary endpoint was all-cause death, and the median follow-up was 3.5 years. These are the biomarkers we incorporated: NT-proBNP, HS troponin T, ST2, EGFR, NT-proBNP for neurohormonal activation, and also sodium and hemoglobin. This is our biomarker profile. Again, we recorded 311 all-cause deaths, and this study was internally validated with bootstrapping in our own cohort with an AUC of 0.79, was externally validated with the PROTECT study with an AUC of 0.75, and now it has been externally validated with the Paradigm Heart Failure trial. So we did a number of models, and if I don't want to go one by one of these models, but I just want to make sure that you realize that in every model we do specific discrimination, calibration, and reclassification as it was postulated by Januzzi and Van Kimanade at the beginning of my talk. So we went through these very strict state-of-the-art statistics to know which biomarkers provide the most information. So we end up that NT-proBNP, troponin T, and ST2, the three of them combined are best. And this allowed us to develop what we call the BCN, or Barcelona Bio-Heart Failure Calculator, that you can find in this webpage. And this calculator is updated as of 1 week, and you have 3 columns. On your left, you have clinical variables. These are the clinical variables every doctor will take in the day-to-day practice. In the middle, you have the treatments, just to stress that we have added very recently ARNI, which is sacubitril valsartan. This is the only calculator that can provide you the risk with or without sacubitril valsartan, also resynchronization and ICD. And on your right, you have the three biomarkers, HS, troponin T, ST2, and NT-proBNP. You can have the risk of death, hospitalization, or the combined risk. So whenever you assess the risk of your independent patient, or of the patient that you're visiting in your clinic, you can use 1, 2, or the 3 biomarkers. And the calculator is going to give you the risk without biomarkers and the risk with biomarkers. So in this particular case, the patient at 1 year had a mortality risk of 13%, but when you add the biomarkers, this patient seems to be much better controlled with a risk of 2.1%. And if you go down, you also have life expectancy of this patient. So without biomarkers, the model tells you that this patient has 10 years of life expectancy. With the biomarkers, it says it's over 20 years. So there is a good tool to provide information on your on-site patient while you're visiting. So let's spend 2 minutes with ST2, which maybe is the newest biomarker I talked today. ST2 is a biomarker of fibrosis, but it also provides surrogate information about stress of the myocyte, and also it's somewhat a biomarker of inflammation. In any case, arterial stiffness generates diastolic dysfunction and heart failure, and particularly cardiac fibrosis generates left ventricular stiffness, systolic dysfunction, and heart failure, and generates tissue heterogeneity, arrhythmias, and sudden death. So whenever we have fibrosis in the heart or the cardiovascular system, we are in risk of developing heart failure and sudden death. What is ST2? ST2 we can find in 2 different forms in biology. It can be in the form of a ligand, ST2L, which is a membrane anchor receptor for interleukin-33, or we can find it in a secreted way, soluble ST2, which is found in serum and plasma and can be easily measured nowadays. Soluble ST2 is a decoy receptor, so the system goes this way. Fibroblasts generate interleukin-33 under stress, and this interleukin-33, which is in serum, connects to ST2 ligand, and this ST2 ligand, through a number of pathways, interacts with NF-kappa B and is cardioprotective. So ST2 ligand is an indication of cardioprotection, whereas an increase of ST2 soluble, which picks up all this IL-33 as a decoy receptor, blocks all these cardioprotective pathways. And that's why we say that soluble ST2 is a fibrosis biomarker, which is the evidence that we have with ST2. We did some studies combining proBNP and ST2. Here you have a survival curve. When you combine NT-pro and ST2 and the 2 are high, survival at 4 years, it's just 20%. If the 2 biomarkers are low, survival at 4 years, it's 90%. We're talking about a very hard event. 4 years survival, 90% versus 20%. ST2 is a marker of fibrosis. Fibrosis is sudden death. Let's look at this study that we performed some years ago. When we combine ST2 and NT-pro, if the 2 are low, the risk of sudden death is 3% per year. If the 2 are high, the risk of sudden death is 71% per year. So if we are now the medical directors and we have to make a decision in which patients we are putting the money for our defibrillators, for our ICDs, I would certainly use biomarkers to better do precision medicine and identify the patient that is going to be more protected and will need it more by using these 2 biomarkers. Also, ST2 predicts response to MRA blockade. For instance, if we are evaluating left ventricular dilatation in the Ephesus trial, if ST2 was low, it doesn't matter if you give placebo or eplerenone. If ST2 is low, there is low fibrosis, the ventricle does not dilate. If your ST2 is high, if you give eplerenone, you prevent dilatation, but if you give placebo, the ventricle keeps remodeling. So are we close to getting into a very much precision medicine with these new biomarkers? We're just getting there. Just a very simple example. For ST2, we have this clinical patient in green NT-proBNP, very high NT-proBNPs of 7,000. At the beginning, we are starting with spironolactone, beta blockers, and it starts to go down, but it never goes down to the optimal cut point, which is 1,000. The patient remains between 2,000 and 3,000, and these are high numbers. What happened if we measure ST2? When we start spironolactone, it goes down. When we give beta blockers, it keeps going down, and the cut point is 31. So we have this patient going down to a cut point of stability. If it has some asymptomatic instability, it goes up again, and it returns to normal. So it's a very good biomarker because the heterogeneity of measurements are very, very small, and the CV is very good. So let me summarize what I just said with these take-home messages. So scores derived from multiple biomarkers integrating diverse biological pathways substantially improve the prediction of adverse events beyond the current metrics. Identifying an optimal panel of biomarkers for assessing heart failure remains critical, and I would not be ready to tell you which is the optimal panel today, but an attractive combination may be NT-proBNP, which is a surrogate of neurohormonal activation and strain, HS-troponin T as a surrogate of myocyte injury, ST2 for extracellular matrix fibrosis and remodeling, and GDF15 for inflammation. Thank you very much.